From the JAMA Network, this is JAMA Pediatrics Author Interviews. Conversations with authors exploring the latest clinical research, reviews, and opinions featured in JAMA Pediatrics.
Hello again, podcast listeners. This is Dimitri Christakis, Editor-in-Chief of JAMA Pediatrics, coming to you, as always, with my friend and colleague, Dr. Alison Galbraith from Boston Medical Center. Allie, how are you?
Hi, I'm good, thanks.
Great to have you back. And we have a new and improved format where we bring a international expert on a particular topic to our virtual studio here to discuss something that caught our eye based on an article we published in JAMA Pediatrics. And today I am delighted to say that we have Professor Jill Halterman, who is a professor of pediatrics at the University of Rochester and the chair of pediatrics there, and the pediatrician-in-chief at Galison Children's Hospital. Jill, great to have you here.
Thank you so much for having me.
Our pleasure. Allie, what made us think of getting Dr. Jill Halterman, who is one of the national experts on delivering asthma care in the United States, particularly low-income children?
Yeah, especially because of all the great work that Jill has done in school-based interventions for asthma, because our paper that we're going to be talking about, or we're using as a jumping-off point, is called Community Health Workers Linking Clinics and Schools and Asthma Control, a randomized controlled trial. It's by Bryant Stevens and colleagues at CHOP. And so recognizing there's a lot of disparities that exist in childhood asthma, worse outcomes for Black and low-income children, the question is, can we better address this problem if we try to target it in multiple settings? So in clinic, but also home and school. And can it help to use community health workers to coordinate between all these different settings? And so community health workers being either lay or paraprofessionals who can be trained to go out and help with navigation and teaching and things like that. So in this intervention, they used community health workers to connect primary care, home, and school to see if it improved asthma control for low-income, minoritized school-aged children with asthma. So this was a hybrid effectiveness implementation trial. They did a factorial design, and they randomized children from clinics in Philadelphia. Children were 5 to 13 years old with uncontrolled asthma, and they were enrolled in 36 different public and charter schools in Philadelphia. They randomized them to either get usual care or to have a community health worker working with them in primary care alone, or a community health worker in school alone, or a combination. And in the primary care setting, the community health workers helped with asthma education, went to visits, did some home visits. In the school setting, they helped with educating school professionals, doing trigger remediation in the classrooms, helping with asthma care plans, and also school-based asthma therapy. So they actually had the meds delivered to the schools, the inhaled steroids and preventive meds. This is important. It was done between 2018 and 2022, so COVID definitely derailed a little bit of what they were doing, especially in the schools. Their primary outcome was changes in asthma control as measured by the Asthma Control Questionnaire from the start at baseline and then 12 months later. And they had some secondary outcomes like symptom-free days, school absences, asthma, emergency department visits, and hospitalizations. So they had 626 kids, and all the groups had significant improvement over time in asthma control, but there were no significant differences between the study groups. However, when they looked post hoc at just the pre-pandemic interval, they did see a statistically significant improvement in asthma control scores for the combined group that combined community health workers in both school and clinic compared to controls. And they saw a little bit of improvement also in day and night symptoms.
So, Allie, just so we're all clear on this, a lot of these kids weren't even in school during the pandemic, right? So it's a little hard to assess
the school-based part. Yeah.
And of course, low-income kids were less likely. You said derailed. Those of us that were doing research during COVID can really relate to the scientists' face.
Yeah.
Okay. What's your first question for Dr. Halterman about this?
Well, I guess I'm just wondering, I know you've done a lot with school-based asthma treatments, but what are your thoughts on the degree to which a community health worker can help in that setting? And how do you incorporate that? Do you think the benefit is primarily for navigation, or are they able to teach families in a way that builds upon what we do in clinic?
So I think that's a great question, because as we think about asthma as a model for a chronic disease that impacts historically marginalized kids disproportionately, and for which there are treatments that we know work if they reach the kids who need them, this model makes a lot of sense. It seems really simple. We have guidelines for asthma care that help us know what treatments are needed for children with different levels of asthma severity. We know the medications work. But the question is, how do we make sure that the kids are prescribed the medications they need and that they're getting them consistently? And what happens in reality is that falls apart for many children, particularly for kids whose families may have a lot of competing demands. And we've thought a lot about where kids fall through the cracks, and it's really at every level of care. And so a model like this, where they're really thinking about connecting all of the places where kids are in the community, in the primary care clinic, and in schools, makes perfect sense to me. Really helping to make sure that all of the pieces fall together so that the kids can get the treatments they need. And they showed that it can work when it happens that way.
It can work. I guess my question for you, Jill, is you said, and it's true, we have effective medications for 50 years. But as long as I've been doing health services research, the challenge of trying to reduce disparities for children with asthma remains in spite of everything. And in spite of your really important work in schools, what's needed to solve this? Why are we still dealing with such disparities in asthma care? And this study, which was hampered by COVID, even insofar as it worked, didn't eliminate it. I mean, it attenuated the differences.
Boy, I wish I had the answer to that. But I do think that connecting systems makes sense because otherwise there are many kids, for example, who never connect with a primary care provider to get their asthma assessed in the first place. When they reach primary care, if there isn't a method of systematic screening, many of those kids aren't even identified as having a level of asthma severity that will require a daily preventive medication. And so they fall through the cracks there. Once medications are prescribed, the family may or may not be able to obtain the medication. There may be financial difficulties or time difficulties. And then the kid has to get the medicine every day for it to be effective. And for something where you don't feel an immediate effect, that can be really tough. You think about blood pressure medication. It's really hard to remember to take it every day. It's the same for asthma medications. To be honest, I think a combination of something like this, as well as some of the newer methods of treating asthma, such as using smart therapy, could really make a difference in these populations.
You jump to my next question, which is what's coming down the pipe that we might add to all of this to really try to move the needle? And I don't know what smart therapy is. Can you tell me what smart therapy is?
So smart therapy is basically using one medication, single maintenance and reliever therapy, using one medication for both symptom relief and maintenance treatment. And the really nice part about that is that when you start developing symptoms, you're going to be using your medication more often. And so you're going to get that symptom relief, but at the same time, you'll get the important anti-inflammatory effect of a maintenance medication.
So it's albuterol combined with steroid?
It's a long-acting beta agonist combined with an inhaled corticosteroid.
It seems like actually smart therapy would be a great thing to do in combination with a community health worker because it's a shift, right? People aren't used to this treatment. And so if you had a community health worker who could reinforce the education about you don't need your albuterol anymore. Yes, here's when you use your smart therapy. I think that actually could be a really great way to increase adoption of smart therapy.
I agree.
You're using this smart therapy. It's an interesting term for it. But you're only using it when you're symptomatic, not as preventive.
No. So it can be used actually both ways, depending on guidelines, depending on the child's level of severity. But it can be used just as a rescue medication, but also as maintenance and rescue. So for example, if a child's prescribed Symbicort, they could take that medication every day as a preventive and also use it when they develop symptoms.
I see. So it's really like unitherapy, one drug. I see.
And it does a number of things. In addition to allowing for an escalation of dosage when the child's getting sick, it also eliminates the confusion because it can be really tricky for families to remember which medication is supposed to be used daily, which is supposed to be used for symptoms. They change colors. Kids may be living in different environments. They may be at one parent's house one week and a different parent's house another week or with a grandparent. And this really takes away all of the confusion around different medications.
Okay, and it's indicated for kids who would, again, forgive me, I'm revealing my level of non-practicing pediatrics here, but it used to be that the goal of getting kids on preventive medications was that they didn't need albuterol, that they were their asthma was well controlled, except when they were sick. So what happened to the kids that used to just be we used to just put on steroids or try to does that not exist anymore?
So the guidelines differ depending on the child's level of asthma severity, and it also depends on which guidelines you're looking at, whether it's the National Heart, Lung, and Blood Institute guidelines or the JINA international guidelines. So it depends on the child's age and their level of severity in terms of which method you would use. But to be honest, in my view, the goal for many folks is to actually eliminate as much as possible the use of a beta agonist alone to treat asthma.
Right.
Knowing that you're really not treating the underlying disorder.
I see. So you would put someone on this smart therapy.
And then
I
they
see.
just amp it up when they are sick.
Correct.
Take it more often.
Interesting.
So imagine if the school health office only had a medication like Symbicort, a combined medication, in the school health office. The child could receive it every day for directly observed therapy, school-based therapy, and they could also get it when they're having an asthma attack at school.
And may I ask how much these unitherapy drugs cost compared to the old generic albuterol and generic steroids?
They're probably pretty pricey.
I don't know off the top of my head, but I do know that one of the initial concerns for our programs was whether you could get more than one at a time, because you'll need one for school, one for home. You can't just have one inhaled corticosteroid for the child in that case. And we have been able to get insurance to cover both.
Interesting.
Mm-hmm. Yeah, in Massachusetts, they actually let people have several all at once because like an inhaled steroid, you know exactly how much you'll use each month, but you might use more than the daily amount because you might have an exacerbation. And so they're allowed in our Medicaid to have more than just that much.
And then when they have an exacerbation, they're using their unitherapy Q2 to 4 hours. They're also using their steroids
Correct.
that frequently, and that's okay.
It actually could be helpful.
Wow.
There's a limit in terms of the number of doses you should be taking in a 24-hour period without escalating care even further. But I do think this is the direction that we're heading, and it's the direction the guidelines are heading. But I would say that even regardless of the use of a combined medication like that, you still need some method to connect all of these pieces together for kids. They need to get appropriate assessments. They need to be able to get the medications based on their level of severity. Someone needs to make sure that they're getting it routinely when they need it. And so the idea of a community health worker or someone like that who can help connect systems for kids makes a lot of sense to me.
See, it's funny because when you said smart therapy, without knowing what it was, instead of thinking, I thought it would be like, it would remind you somehow.
Huh.
You know, there are some people who've tested different methods of reminders, smartphone reminders or different things. We talk a lot about, for example, pairing taking your medication with some sort of routine like brushing your teeth. And those things can be very helpful.
Right.
But again, none of those methods have solved the asthma problem. And I think that more needs to be done.
Have you done studies using smart therapy in schools? I'm just curious if schools welcome that because maybe it's a little simpler or if they feel like, oh, this is new and different. We don't know how to handle that.
Yeah, so for our current study with teens, a lot of the providers, the specialist providers or primary care providers are the ones who determine what medications the teens are on. But many of them are prescribing smart. And again, for its simplicity, its effectiveness, it's worked really well. Now, we don't have data from the study yet because it's an ongoing trial. But in terms of acceptance and the ability to have it administered through school, it's worked well.
And so, Jill, you're doing studies now, which is great. Have there been head-to-head comparisons of unitherapy versus conventional therapy that have shown that it works better?
Yes, most of them have not been done in kids.
Okay.
But there are studies, and hopefully there'll be more in kids soon.
So for the pediatricians listening then, let's give them some really practical advice. Walk us through now your approach to primary care management of a child who's, let's say, known to have asthma.
So assuming we know they have asthma, the first step is obviously getting kids in for care. Once they come in and we're doing an assessment, the real key piece, I think, is doing a systematic severity assessment or control assessment. And the reason for that is because what we have found is that if a provider asks a general question about asthma in the context of a visit, how's Johnny's asthma going? Many caregivers will say, it's fine. And I think that's in part because they're used to their kid having asthma symptoms. They've normalized it. They may have a family history of asthma. They don't think it's unusual. But if you ask specific questions, how many days per week is Johnny having asthma symptoms during the day? How many nights is he awakened with symptoms? Is he limited in his activity due to his asthma? Then you really find out a lot more about what he might need in terms of management, because our goal is really for kids with asthma to be symptom-free.
Right.
And to be able to do all the things that they want to do. So the first step is systematic screening. And then it's providers understanding the guidelines. And, it's tricky. The guidelines aren't simple. There are some nice tables that you can look at to help understand the levels, but they change. And then there are new guidelines that are out. but really thinking about what do the guidelines tell us about what these kids need next. Should they be on a daily preventive medication? Would smart therapy be reasonable for this child depending on their age and level of severity? And also, is a specialist visit warranted? We find that many of the kids in our practice are not seeing a specialist, even though they should, according to the guidelines. And that can be really important if they need assessment for comorbid conditions, for example, like allergic rhinitis or reflux. Or also if they need a level of therapy that you wouldn't be providing in the primary care setting, like a biologic. It's really following those stepwise treatments. And then I would also say it's really important to help families understand how to manage the asthma. It's confusing, knowing the difference between the medications when they need to be used, making sure they can pick up the medications they need and have access to them in the different environments that a child might live. And if you can collaborate with the schools to make it happen more systematically, I think that's even better. The last piece is ensuring follow-up. So if a child with asthma is not well controlled, they need a change in their management, and then we need to see them back again or have some sort of follow-up to make sure that we're achieving the goals of therapy. And if they're not, providing that step up in care or a referral to a specialist.
That's where I think that the community health workers could be really helpful, those last couple things. If a kid isn't doing well, they might see it at school more regularly, or they might help the family realize like, oh, you're almost out of your meds. Here's what you need to do to get a refill. Oh, you don't have any more refills. How do you reach out to your doctor to get them? Like all those like little things that can make it hard for you to stay on track.
I agree.
And the pediatrician's role in all this, Jill, you mentioned that they should be liaising with the school. Is that something that you feel is fair to ask of them, reasonable, necessary?
So that's a great question.
Speaking as a chair of pediatrics with your faculty who are of primary care who are overburdened as it is, go ahead.
I know. And we ask so much of our primary care teams. I would say having someone available to facilitate that would be the best, but that's not always available. We are actually looking into systems of communication between schools and healthcare. I don't know if you have anything like that where you are. It's a simple concept, but tricky to actually implement. So we're hoping, for example, that our school nurses could have direct communication through our EMR to the primary care teams so that they could let us know if a child's experiencing symptoms at school because we may not be aware. Or we could let them know if we're starting a new medication that we would love to see delivered at school. And that communication back and forth could really be a game changer in care, not just for asthma, but for many different situations like diabetes care or kids who have an injury at school or whatever it might be. It's got to be simple, though, or it's not going to happen because primary care providers just don't have time.
I want to thank you so much for your time. I learned a lot about asthma care. I hope that our listeners did too. Jill, thanks for all you do. Thanks for joining us. And thanks for trying to reduce disparities in asthma care.
Thank you.
This episode was produced by Shelley Steffens at the JAMA Network. To follow this and other network podcasts, please visit us online at jamanetworkaudio.com. Thanks for listening.